Good afternoon, everyone. Welcome to the second panel of oral and maxillofacial surgery in this virtual winter school. I'm happy to have you all here. Today, we're going to cover more practical topics in maxillofacial surgery. First, we're going to talk about fresh socket implantation. Then we'll review the basic techniques of local anesthesia in mandible. And finally, we will talk about how to surgically remove impacted teeth. Our first speaker is Dr. Razmara, who is one of our attending staff in TUMS, and she will talk about fresh socket implantation. During her lecture, if you have any questions, feel free to write your question in the chat box. I will make sure to collect all your questions and ask her at the end of the lecture. Dr. Razmara, thank you very much. I know that you have prepared many interesting videos for our students, so we're all ears for your very interesting lecture.
Thanks to Dr. Hashemi Nasa for introducing me, and hello to all their students. I hope today's topic is interesting for you. As you know, I'm going to explain about fresh socket implantation or immediate implantation. I have prepared some slides and videos for you to enhance acknowledgement to surgical technique, indication or indication, and everything about immediate implantation. I hope useful for you. Would you please play my slides? Okay, at first I speak about what's the immediately implant or immediate implantation. The implant placed immediately at the time of extraction. Of course, the patient was very happy if they here can use implant immediately after extraction their teeth. But in this procedure have advantage and disadvantage that we must know about them. The primary advantage of immediate emplacement is shortest healing time and combined tooth extraction with implant placement. The primary disadvantages of immediate emplacement is related to different anatomy of roots or roots of extraction tooth. In aesthetic zone include apical recession of facial gingival margin and loss of papilla immigration height. Of course, each technique is its own advantage and disadvantage that we describe this. Patient must clinical and paraclinical evaluation. For example, we must evaluation interocclusal space and type of gingiva and periodontium, and then attached gingiva. And one of way for evaluation paraclinical patient use the CBCT technology. CBCT be used for evaluation bone, vital structure in the jaw, and root formation. Immediate placement implantation can be considered if the bones to be removed is not infected and can be removed without the loss of alveolar bone. Pay attention if the tooth has acute infected lesion. My treatment was not true. and we must extract the teeth, and then we must implantation with a pass of period of time. A traumatic extraction technique is very, very important in this procedure. Using periotome will help us to minimize damage bone and help facilitate implant placement. And we try to extraction of tooth without any elevation of flaps. Ideally, the implant should be placed about 4 millimeters deeper than the root of tooth for achieve proper primary stability. You can see in the picture. At this stage, the vital structure of jaw must be considered. In this stage, CBCT can help us for detected maxillary sinus, nasal cavity, or in mandibular canal and mental trauma. Another point in this technique is pay attention to the drilling angle or angulation drilling. Drilling the implant site at the correct angulation can sometimes be difficult, especially when the root direction is not suitable. You can see in the right picture, the root direction is different from direction of drilling. The implant should be slightly below the height of crest bone, about 3 millimeters below of free gingival margin for resorption of bone resulting from extraction, especially in aesthetic zone. We must consider about resorption of facial bone and soft tissue remodeling after tooth extraction, and better place the implant 1 millimeter palatal to the center of the root. Finally, we try to place implant in the best position that is less affected by bone resorption. When we place the implant in a fresh socket, always we have a gap between body of implant and the facial bone. If the gap is less than 2 millimeters, we don't need to use bone material. And if the gap is greater than 2 millimeters, we need the bone material such as allograft. But this procedure is a controversy between a surgeon. Sometime we decided to insertion implant in posterior zone. Of course, we know fresh socket or immediate implantation prefer to use in aesthetic zone. But sometimes we decided insertion in posterior zone. The best position in the mandible is interseptal bone, and in maxilla, the bone located in forcation. Bone graft and membrane are also required to augment it and reminding the extraction socket. picture show the located of drilling in posterior of maxillary. The left picture show the bone located in forcation, and the left picture show drilling for implantation. In general, the increased demand for shorter rehabilitation time have led to demand for immediate implantation. Although this method offers many advantages like minimal number of surgical procedures, less morbidity, and shorter rehabilitation time. In this associated with some complication, such complicated extraction, localized bone defects surrounding in implant, and improver implant position because of the socket anatomy. I hope this contact I hope this contact was not boring. And if you have any question, I will answer them after watching videos. Would you please?
Thank you very much, Dr. Asmara. There's one question for you, but I think that if you just play your video, the question will be answered. And if that student can't find the answer of the question, maybe you can answer that later. Okay?
Okay, so thank you
for your videos.
In this video show the fresh sockets in third premolar, second premolar, and it's very, very important to automatic extraction of tooth. It's better curettage the sockets. If any lesion can be there removed, and some texts suggested that curettage the sockets can improve healing and better osseointegration implant in the sockets. Pay attention, chronoapically, the implant should be placed deep inside the extraction socket, about 4 millimeter deeper than root tooth, for achieve proper primary stability. Direction of drilling must be evaluated by parallel pin or um, uh, the drilling, and then we certain the direction is correct, then drilling finally. In this case, we don't need any bone grafting. Insert the gap of between implant and buccal bone plate.
We've already have some questions for you, Dr. Asmara, and I'm trying to answer some of them in chat box.
Thank you for you.
Okay, sure. But when you finish your videos, maybe I can ask you some of the questions. You're ready for your next video?
Yes, of course.
Thank you very much, Dr. Asmara. There is one question here for you. I tried to answer it, but I think it still needs more to talk about. Somebody has asked you about the angulation of drilling in different regions, and I just told them that in anterior areas, we usually drill a little more palatally. And they're asking you about how palatal do we go, or is anterior palatally is for enough bone thickness? I mean, do you do that to save the bone thickness in buccal areas?
Yes, of course. I decided to the best position for implant that save bone. For example, when in the slide we show that the position of a root of teeth may be buccally, okay? And if the direction of tooth with drilling, the buccally bone was perfored. And then we must the angulation of drilling tilt palatally that we can gain primary stability from palatal bone. And it's better parallel to adjust teeth and can get good primary stability.
Right, thank you. So from what you said, I can just conclude that there are three factors affecting the drilling angulation. One, we do that because we want to save the buccal bone. We don't want to have any bone recession. Second, we do that because we want to have primary stability from the palatal bone. And third, we just bear in mind about the emergence of the crown we're going to put on that implant. If we plate the implant a little more palatally, the final crown will look better. Okay, thank you.
Thank you, Dr. Hashaminasa, for best explain this answer.
Okay, thank you. We're ready for your next video.
میخوای اگه که چیز زمان نداریم چیز کنیم.
Thank you very much, Dr. Asmara. There has been a question. Somebody asked you to just introduce them a textbook in implant dentistry. I just told them that here we teach Mish text implant dentistry book. But if you have any other book in your mind, you can tell them. And we are ready for your next video.
Yeah, after next video, we can better video better.
Okay.
Okay, after answer this question. Yes. In this case, bone grafting was used uh, insertion gap of implant and buccal bone.
Thank you very much. And I think we still have one more video, right?
Yes, Dr. Hashemi Nasab, it's last video. I hope it's not boring. Implantation in posterior of maxilla. Fresh socket in posterior zone.
I would like you all to pay attention to this step. It was difficult for the surgeon to just drill in the interroot septum. So she just took a round burr to just reduce the septum for a little bit to create a surface so that the drilling can be done exactly at the middle of the septum. You see, this is the first premolar there, a two-rooted teeth. And as Dr. Asmar already told you, it's better not to just stay in one socket. It's better to drill in the middle of the socket. So it's not always easy to drill in one thin septum. So sometimes you have to just soften the septum, create a surface, and drill in the middle of that septum, as you see here.
I hope you enjoyed this virtual class. Although the face-to-face class and live surgery is much more enjoyable, I'm very happy to spend a little time for your dear one. If any question, I will answer them.
Thank you very much, Dr. Razmara. Yes, it's amazing to have this many participants at this time of day. Thank you very much. I think you're all clear, and I tried to answer some question in chat box. I know you went through a lot to prepare all those videos. They were all your original work. Thank you very much. They were amazing. We enjoyed a lot. Thank you.
Thank you for you, and have a nice day. Goodbye.
Thank you. Bye. So we're going to have a short break. You're going to watch a short video clip, and then we'll be back with our next presentation. Thank you very much. Okay, thank you very much, everyone. Now we're ready for our next lecturer, Dr. Nima Dehkhani, one of our attending staff here, and he's going to talk about basic techniques of local anesthesia in Mandeville. Dr. Dehkhani, thank you very much, and we are ready for your very good lecture.
Hello.
Hi.
Hi. Hello, dear colleague and students. I'm Dr. Nima Dehkhani, oral and maxillofacial surgeon, and I hope all of you being well. And in this section, I want to talk about one of anesthetic technique in the mandible. It's inferior alveolar nerve block, and Uh, it's one of the common technique for anesthesia of the mandible, but although it's common, but many error and pitfall in this technique, and I think it's not bad to review this technique, and if you have any error or pitfall in this technique, we can help you to review this issue. First, we will show you a video about this technique, and after that, if you have any question or uh, any doubt about this technique, you can uh, we can talk about this. I'm ready to play the video.
Okay, thank you. Sure.
The mandibular nerve, which is itself the third branch of the trigeminal nerve. Facial surgeon. In this video, I want to demonstrate the inferior alveolar nerve block technique. This technique is the most common anesthetic technique to anesthetize the mandible and its hard and soft tissues. At first, we should know about the neuroanatomy of the inferior alveolar nerve. The inferior alveolar nerve is a branch of the mandibular nerve, which is itself the third branch of the trigeminal nerve. The target of this block technique is to inject local anesthetic in the vicinity of the inferior alveolar nerve just before it enters into the mandibular foramen to reach the mandibular canal. This image shows that local anesthetic after that is injected. Notice that as the local anesthetic is injected, the lingual nerve is also often anesthetized, leading to anesthesia of the anterior 2/3 of the tongue, all the lingual gingiva, and the mucosa of the floor of the mouth. As described earlier, the target of the block to place local anesthetic just above the mandibular foramen. This foramen is the entrance of mandibular canal. The inferior alveolar nerve enters to the mandibular foramen, so by injecting local anesthetic solution above this foramen, we ensuring that local anesthetic penetrate inferior alveolar nerve as well as lingual nerve in most cases. Areas anesthetized by an inferior alveolar nerve block including hard tissues and soft tissues area, which described as the follow. Bony areas that get anesthetized include mandibular teeth to the midline, body of the mandible, and inferior portion of the ramus. Soft tissues that get anesthetized include the skin and mucous membrane of the lower lip, the skin of the chin, the labial gingiva of the anterior teeth. In addition, as mentioned earlier, the lingual nerve often get anesthetized, leading to anesthesia of the anterior 2/3 of the tongue, the lingual gingiva, and the mucous membrane of the floor of the mouth. The indication of the inferior alveolar nerve block, including procedure on multiple mandibular teeth in one quadrant, or when buccal soft tissue anesthesia is necessary, or when lingual soft tissue anesthesia is necessary for dental procedure. This is the ramus of the mandible. This is the anterior border of the ramus. The anterior border of the ramus features a concavity. This concavity called coronoid notch. We start our block by identifying this coronoid notch by means of TUMS. The height of the injection coincides with the midpoint of the fingernail. In most patients, this line lies 6 to 10 mm above the occlusal plane. The patient asked to open her mouth widely open. The coronoid notch and the anterior border of the ramus was palpated. As noted earlier, the height of injection coincides to height of nail tip. The next step is to identify the trigomandibular raphe. It extending from the posterior of the tuberosity to the anterior border of the ramus. Just lateral to the trigomandibular raphe, there is a depression which called Trigomandibular Depression. Here the cap needle rests now in the Trigomandibular Depression. Finally, the entry point for needle is the intersection of the line between height of the fingernail tip and trigomandibular depression. Here's the first demonstration. The index finger of non-dominant hand is placed in the coronoid notch at the anterior border of the ramus of the mandible. The needle comes from contralateral side from the corner of the mouth and then inserted in trigomandibular depression and advance for 20 to 25 mm until bone contacted. Once bone is contacted, the needle withdraws slightly, then injection of 2/3 to 1 cartridge of the local anesthesia is injected after negative aspiration. Then the needle is completely withdrawn. Here I demonstrate the inferior alveolar nerve block for the next patient. I select the lidocaine for injection. I put the carpool in the syringe. I select the long needle with 27 gauge. Completely put the needle in the syringe. First we test the syringe and then we located the landmark in the mouth. The patient should open the mouth completely. And finally, we block the long buccal nerve for anesthetize the buccal mucosa of the molar areas. And we should cap the needle with one-handed technique. And here is the next patient. Again, we select the line needle. Here we located the landmark, Trigomandibular Raphe, anterior border of Ramus. We put the finger on anterior border, and the entry point for the needle is between the line from the fingernail tip to the Trigomandibular Raphe in the Trigomandibular Depression. And finally, we anesthetize the lymphacal nerve and cap the needle with one-handed.
Thank you very much, Dr. Dekhani. You know, it's always a challenge for dentists and dental students to gain good anesthesia after a mandibular nerve block. There are some questions for you here. Somebody has asked you, can patients have headaches after injection in some cases?
It's on?
Yeah.
Okay. No, I said normally we shouldn't have any headache after local anesthesia. Maybe this is refer to some stress about the patient if they have any headache. But normally we don't have any headache after normal and standard local anesthesia.
Yeah, right. I totally agree with you. It's not normal to have headaches after local anesthesia injection. Maybe the stress is the causative factor, or maybe some sort of muscle spasm here on the area of injection, and the pain is referred.
Yes.
Allergy?
No, it's not. No. The sign and symptom of the allergy isn't the headache. The other sign like erythema or sign like this should be the allergy.
Right. There's also one more question for you. How do you choose between infiltration or inferior alveolar nerve block? I mean, they're asking you about the indications of these injections.
Please repeat the question.
How do you choose between infiltration techniques and inferior alveolar nerve block?
Okay.
What is the indication of each one?
It's in totally we didn't have any indication for infiltration in mandible for normal anesthetic solution like lidocaine and prilocaine, and the standard technique for anesthesia of the mandible is inferior nerve block in many cases, and for anterior tooth we have two options. We can choose mental block technique for just premolar and canine and anterior tooth area, but in some cases and in very limited indication we can use infiltration by articaine because the articaine have some articaine can use infiltration in anterior area because the bone was so thin, and this anesthetic solution can infiltrate much better in the bone. But normally it's better you use the block technique like inferior alveolar technique or mental technique to anesthetize the tooth, and the infiltration not normally for completely predictive to anesthetize the teeth, and we don't prefer this technique in the mandible.
Yeah, you're right. In cases we need pulpal anesthesia whenever we want to extract any teeth, or when we want to perform endodontic treatments, we absolutely need to perform the block.
Block technique, yes.
Anesthesia. But in superficial cases, just like when we want to do an incisional biopsy on the buccal mucosa or anywhere else in the mouth, infiltration would suffice. But if we need pulpal anesthesia, just take in mind that you have to have a nerve block in mandible. Okay, yes, thank you. Yes. There's another question for you. They have asked you if you touch the bone at the end of the injection. I mean, you need to touch the bone, then you insert your needle, or you just inject when your needle is inserted enough?
After we touch the bone, we should withdraw the needle 1 or 2 millimeter to prevent the injection superiously. And after that, we should aspirate to prevent the intravenous or intra-arterial injection. And after that, we can inject the solution.
Right. And there's one more question. Is it possible to use infiltration for patients with middle alveolar nerve anesthesia in first mandibular molar? I don't know anything called middle alveolar nerve. We have middle superior alveolar nerve in maxilla, but in mandible, no such thing as that.
No. The question is about maxilla?
No. It's written mandibular molars, but we don't have any nerve as middle alveolar nerve. We have inferior alveolar nerve inside the bone, and the mental foramen, it just comes out at the mental nerve.
Okay, maybe it means the myelohyoidine nerve in first or second molar, and we can isolate this nerve, this accessory nerve, in some cases with infiltration in the lingual sulcus to anesthetize this accessory nerve in some cases. Maybe it's the question.
Yeah, right. There are of course some accessory nerves, but you don't count on them. I mean, you just go for the mother nerve, and then the accessory nerves are anesthetized on the way. Right. Okay. You're right. Thank you very much. Thank you very much, Dr. It was a pleasure having you here. Thank you very much for your very nice video. We're so happy to have you here. Thank you. Bye.
Thank you. Thank you very much. Have a good day.
Thank you.
Goodbye.
Okay, so let's just watch a short video clip, and we'll be back with our next lecturer, Dr. Parhiz. Okay, thank you very much. This very beautiful piece was played by one of our students, Amir Mahjoubi, and he's so talented. Thank you very much, Amir. Good afternoon, Dr. Parhiz. We're so glad to have you here. I know you're so busy these days. We're very honored that you have accepted our invitation. Dr. Parhiz is the vice head of our department.
Thank you so much, Dr. Hashim Nassab. Hello. Hello, everybody. Welcome to the virtual winter school of the Tehran University of Medical Science. I'm Dr. Ali Reza Parhiz, oral maxillofacial surgeon and associated professor of dental school. I hope all of you are fine and healthy and far from the COVID-19. Now, in the last session, we are going to discuss about impacted third molar surgery. Let me to share my screen. Okay. Okay, do you have my slides?
Yes, we do, Dr. Parhiz.
Okay, thank you so much. As all of you know that the surgery of the impacted third molar is one of the most common surgeries that a surgeon will do during his or her practice in the office. In most of countries, especially in Europe, I know that this kind of surgery is done under general anesthesia, but in Iran and in some other countries, it's done under local anesthesia and it's office-based. Okay, as most of surgeries, we will start with the indication of the third molar surgery. Here is the list of indication. As you see that the prevention of periodontal disease, dental caries, Pre-Coronitis, and prevention of root resorption, in which we'll discuss by one and show you the slides and the photos of such these conditions and such these indications. Impacted teeth under a dental prosthesis, prevention of odontogenic system tumors, and treatment of pain of unexplained origin, and also prevention of jaw fracture. Here, we have a mesioangular third molar, as you see, with resorption of distal bone of the second molar. In this situation, the patient will lose the third and second premolar. So, to preventing of such a catastrophe or tragedy, we prefer to do or removing the third molar before this. Another indication is to prevention of dental caries, as you see that because of close contact between the third and second molar, we have caries in distal part of the second molar and also in the crown of the third molar. That's why we prefer to do or removing the surgery, removing the impacted third molar before such these caries, because if this caries spread more in the crown of the third and second molar, the patient also will lose both of these, second and third one. Another reason to removing the third molar is to prevention of pre-coronitis, a situation which is sometimes life-threatening. It means that we have some infection and inflammation of the soft tissue, which is covered the third molar in the distal part of the second molar. This situation is much more, it's very painful, and sometimes patient has severe fever, trismus, and sometimes will cause bad signs like odynophagia, which is indication of hospitalize the patient. So to prevent such this situation, we have to remove the third molar. Another reason is to prevention of root resorption. Sometimes when there is very close contact between the third and second molars, it's better. And we prefer to removing the third molar before such as this catastrophe happen, because the second molar also is lost in this patient. And another reason to removing the third molar is an impacted one under a dental denture. In this patient, we have to remove the third molar, otherwise we have some scars in the soft tissue under the full denture. Another indication is to prevent of odontogenic system tumors. As you see that in this patient, we have very large pathologic lesion around the crown of the third molar in the right side, which is mostly a dentition cyst. Sometimes the patient had some pain in the face, which are not explained by the origin, like TM joint or the facial muscles. So we prefer to removing the third molar, maybe or reducing the facial pains, but mostly not. Another reason that we prefer to removing the third molar is that because of the socket of the third molar, we have a weak point at the angle of the mandible. So if the patient had a direct trauma to the mandible, maybe we have a fracture line in the angle, sometimes unilateral or sometimes bilateral angle fractures. As we have some indication, also we have some contraindications for removing of the third molar. One of them is the extreme of age. It means that in very young patients, less than 15 years old, we prefer not to do surgery. As a rule, as a general rule, it says that it's the best time to removing of the third molar is when 2/3 of the root is completed. Otherwise, we prefer not to do the surgery. If the root is not completed, removing of the impacted teeth will be very difficult and more destructive. Exactly, in the elderly patient who are older than 35 years old. Again, as a general rule, we say that in a patient more than 35 years old, if they have completely or bone impacted third molar with no sign of caries, dental or pathologic lesions, or any other indication to removing of that, it's not indicated. It's better to follow up the patient each 1 or 2 years for a long time. In most patients who have impacted tooth to surgery, they have also some compromised medical status. As the age increasing, the incidence of cardiovascular disease, pulmonary disease, and any other situation in which the medical status of the patient is compromised will increase. So it's better to don't do surgery in patients who are older than 35 years old, and also they have some medical problems that makes the surgery much more difficult. Another contraindication is close contact between the impacted third molar and the vital structures of the mandible and maxilla. In the mandible, close contact to the inferior alveolar canal and the root of the second molar, as you see in this picture, makes this surgery almost impossible if you want to do without any complications. Removing of these impacted teeth will cause some nerve damage and also damage to the distal root of the second molar. So if there is no sign of caries, dental caries or pathologic lesions, it's better to keep the impacted teeth here and just follow the patient each 1 or 2 years. Sometimes the surgery of the impacted teeth is very simple, but sometimes it's very difficult. To determine the degree of difficulty of the surgery, it's better to classify the impacted, the kind of impaction. There are some different kind of classification. First of all is according to the angulation of the impacted third molar, according to the, to the second molar. As you see, we have 4 kind of impaction. This is mesioangular impaction. The second one is horizontal impaction. The third one is vertical impaction. And the fourth is distal angular impaction. In the mandible, the most easiest one is mesioangular and the most difficult one is distal angular impaction. The vice versa in the maxilla. In the maxilla, the most easiest is distal angular and the most difficult is mesioangular impaction. we have also another kind of classification. It's according to the anterior border of the ramus. If whole crown of the impacted tooth is in the anterior, according to the anterior border of the ramus, it's class 1 of Pellan-Gregory. Class 2, in class 2 impaction, half of the crown is anterior to the ramus of the mandible, and in class 3, it's completely behind the anterior border of the ramus. Another classification is according to the occlusal plane. In class 1, the crown is the same plane as the second molar, and the class B is half in the occlusal plane of the second molar, and in class C is completely or bony impacted tooth. So in class 1 is the most easiest, and class 3, Pellan-Gregory, is the most difficult. Exactly, the class A is the most easiest, and class C is the most difficult. So in the mandible, a distoangular class C and class 3 is the most difficult impacted third molar to surgery. Okay, now we want to discuss about the techniques. Okay, it's the first technique to removing of the impacted tooth. Don't worry. Before to show how we remove the tooth, it's better to discuss about the incisions. As a general rule, to do a surgery, it's better to have a good exposure and good illumination. We don't want to discuss about the illumination, it's according to you. But for exposure, for a good exposure, we have to make a good incision. One of the most common incision here to removing the third molar is pocket incision, in which the blade is going in the circular of the sulcus of the first and third molar. It's begin from the mesial angle of the first molar up to the distal angle of the second molar, and then go up in the ramus on the anterior border of the ramus. This kind of incision is done if the impacted third molar is in class 1 and class A. That is not very bony impacted. But if we have much more bony impacted teeth, we prefer to have an incision, vertical incision. It's releasing incision at the distal border of the first molar. It makes much more exposure than the pocket incision. Exactly in the maxilla also, we have a pocket incision to removing the third molars, which are not so impacted, but in the much more complicated impacted maxillary wisdom teeth or third molar, we prefer to have a releasing at the mesial angle of the second molar, as you see here. After making a good incision and exposure of the third molar, to removing of a mesioangular third molar, we have to have a dental cut at the distal part of the impacted teeth, to removing the distal part and make enough space to push the impacted teeth distally and removing whole the impacted tooth. In the horizontal impacted tooth, again, we have to remove the bone to expose whole the crown, and we have to kind of dental cut. First of all, is vertically to removing the crown completely, and then we have another cut horizontally to separate the tooth, the roots, and then we will removing the roots by one. In a vertical impaction, we can separate the tooth in two parts by vertical cut in the middle of the tooth, and removing each part separately. Of course, the first part will be the distal one. And the distoangular impaction is one of the most difficult surgery. In this kind of surgery, we'll remove the crown first, and then we'll separate the roots and removing them by one, or we can make a hole in the middle of the roots and removing them by a cryo elevator. Okay, before we go to see a video about the surgery, about the third molar surgery, I want to say that there are different opinions about the preoperative systemic antibiotic administration for the patient. In some countries or some others believe that prophylactic administration of antibiotics, it's very useful to removing or in the surgery of third molar, but in the other articles, they believe that it's not useful. It's the same as the preoperative systemic antibiotic administration. So according to the law in your countries, you will prefer to prescribe prophylactic antibiotics or may prefer to prescribe antibiotics after the surgery. It depends on you. At the end, I want to say that if you want to be a surgeon, okay, be ready to go to the war. It's like a war. Now we want to show you a surgery about, to show you a movie about the third molar surgery. Here is panorex of a patient. She's 22 years old and she wants me to removing the third molar in the left side of the mandible. This is a mesioangular impacted third molar. As I mentioned before, this is the technique in which we want to removing the third molar. Okay, let me starting the video. Do you see my video, Dr. Hashim Nasa?
No, the video is not playing. You can still see your last slide.
It's now playing. Do you see the video?
You can hear the sound, but still no video.
No video?
Maybe you should stop sharing your screen and then you start sharing it once again.
Okay. Let me. Now?
Yeah, there's
Okay.
your video.
Very good. Very good. Of course, I know that unfortunately you cannot see this video as I'm watching it because of the internet. It's very slow. It's demonstrating for you. It's very slow. I know that. So at the beginning, we're starting to make an incision. This incision is a little bit smaller than the incision as I told you before. It's a pocket incision in the sulcus of the second molar and distal part of the second molar. It's extended on the anterior border of the ramus. The soft tissue and the periosteum is removing it's from the bone, separating from the bone. And as you see, the crown of the impacted teeth is exposed now. We separate the periosteum from the bone completely. Okay, now the third molar is completely exposed to the mouth. At the first, we reducing the bone around the crown of the third molar. I'm so sorry this video is not so professional because I make this video in my office. I know that the hand of my assistant is sometimes in the front of the camera. I'm so sorry, I'm not so professional to make a video. Okay, in this part, I'm removing the bone around the crown, as you see, to exposing the height of contour of the third molar. During the removing of the bone, we have to good irrigate to preventing the heating of the bone. Otherwise, the bone will be necrosed and we have some sequester of bone here. and makes very severe pain after the surgery. Okay, now, after removing the bone around the crown, we start to make a dental cut. It's done by a fissure bore. It's a carbide bore. We start to make a dental cut in the middle of the crown. Okay, now the dental cut is completed. We will separate the distal part using an elevator. As you see that, the distal part is separated from the crown. We're removing the distal part. So we have enough space at the distal part of the third molar. So we can push the third molar to this space by an elevator. And now we can remove all the impacted teeth. When we're removing the impacted third molar, we have to check the dental socket. As you see, we have to remove the remnant of the dental follicle. See? And we will irrigate the dental socket and check it for any bone debris, dental chips, and dental fragments. Okay, at the end, we want to suture the incision. As you see that we started the suture at the papilla distal of the second molar. It's a key point when you want to start the suturing. It's very important that the enter point of the needle must be a little bit mesially according to the papilla, because we want to move apically this flap as much as possible, as you see here. Otherwise, we will have a periodontal defect at distal part of the second molar. It's very bad. And at the end, another suture at the releasing on the anterior border of the Ramus.
Thank you very much, Dr. Parhiz. You did it so fast. Normally, it's not usually done this fast. It's because of your art and expertise. Thank you very much.
Welcome, Dr. Hashim. Thank you so much.
Okay, there's one question for you. What was the indication of extracting this tooth? You did it prophylactically, right?
No, it's not prophylactic. Of course, maybe we can say prophylactic because we want to prevent of dental caries in distal part of the second molar. Yes, it's prophylactic. The patient had no sign or symptoms like dental caries, pain, or pathologic lesion, but she was very young. She was 22 years old. So to prevent any bad indication, like bad condition, like pathologic lesion or caries in distal part of second molar, we prefer to do the surgery. Yes.
Yeah, there's one more question for you. Some dentists don't suture after extraction. Why?
Yes.
Is it normal?
Yes, I've seen such articles that they prefer not to do the surgery. They believe that it makes patient, of course, they believe that the patient of this kind of surgery and not suturing have less pain. Of course, they say that they make an open way to exit the exuda which are produced in the surgery site. I'm not sure about that, but I've heard that.
Me too. I don't trust my patient not to suture anything. They might bleed, right?
Okay.
I use sutures too. Okay,
Yeah.
I see there are no more questions here for you. Do you have any more videos or we're just done for today?
No, unfortunately, this is just one.
No, it was fun. It was always fun watching you doing these surgeries. Thank you very much. We enjoyed a lot.
Thank you so much. Thank you so much.
Okay, no more questions. Thank you very much, Dr. Paris, for giving us your time.
Welcome, Dr. Hashem Asab. Goodbye.
Bye. Okay, I think our panel of maxillofacial surgery is finished here. Thank you very much, everyone, all of you. Thank you very much for being with us. Thank you very much for your questions and paying attention. Hope to see you soon here in Tehran in person. Bye, everyone.
Hello, everyone. I hope you have enjoyed these days. We are going to start the session in the afternoon. I'm Dr. Shahabi, the moderator of Dental Materials course. First, we're going to start this session, and we have a movie about Dental Materials lab, and then my colleague, Dr. Behrouzi Bash, has a lecture. I hope you enjoy it.
Good afternoon, everyone. Welcome to my presentation. Thank you for joining us today. First of all, let me express my special thanks to international efforts of Dental School of Tehran University, especially Dr. Shakib, for their great efforts to organize this event. This is Marjan Behrouzi Bash, PhD in Dental Biomaterials, Assistant Professor of Dental Biomaterials Department of Dental School of Tehran University of Medical Sciences. As you can see on the screen, I'm going to talk about the introduction to properties of dental materials. How to evaluate the materials properties is the topic of my presentation. This is an important question from many researchers, that when we want to set up a research project and when we want to evaluate the properties of a material, which test methods is more important, and how we have to set up a test method. Setting up a test method for evaluation of properties of materials, you have to consider two different aspects. First of all, you have to consider to the usage of the materials, what's the purpose of the usage of that material. For example, if you want to use this material as an anterior restorative material, maybe the optical properties is the most important feature of that material. If you want to use a material as a posterior restorative, mechanical properties is more important. And for example, if you want to use endodontic sealer, you have to consider that the solubility is more important, and also the biocompatibility of this material is very important. So first of all, you have to consider to the usage of the material, the purpose of the usage of that material. The second step is that you have to consider to the nature of that material. For example, if you want to use a brittle material, you have to know that a brittle material cannot tolerate the tensile forces. So if you want to set up a test method, you have to consider this material cannot any tensile forces. You have to set up a test method with a compressive direction, with a downward direction. And also you have to consider to your facilities and your equipment that and the available equipment. So today I'm going to talk about different test methods. I focus on the mechanical properties, and besides I try to introduce you our facilities and equipment in Dental School of Tehran University of Medical Sciences. You have to consider that for evaluation of the properties of a material, some facilities and equipment are needed. For example, for mechanical properties, physical properties, and different properties of material, you need to different equipment, different mechanical properties, mechanical equipment for evaluation, the compressive strength or different strength, flexural strength, tensile strength. We are talking about all of these properties, and also for physical properties. A dental biomaterials department of Tehran University provides 3 laboratories, including laboratory of mechanical and physical properties of materials, laboratory of synthesis of biomaterials, laboratory of biomaterial analysis, and also we have a great collaboration with other research centers. First of all, I'm talking about the laboratory of evaluation of mechanical and physical properties. In this lab, we have different accessories, different devices, different equipment that is needed to set up a test method. Different accessories and equipment which we have in our department include different molds and accessories. Incubator, we have both wet and dry incubator, thermocycling, load cycling, and acid erosion test. And also we have different cutting machines. I am talking more about the different cutting machines, which one is better. I'm talking about the benefits of each one. And also a universal testing machine, which is needed for evaluation of mechanical properties of materials. As you can see on the screen, these are different molds which they are needed for evaluation of properties. You have to consider that for any test method, first you have to prepare the specimens. You need for preparation of specimens, you need to different molds. Here it's the amalgam filling molds. We are designed according to ISO specification, and here the molds of the molds of impression materials, we are designed also according to ISO specification, and different molds. We have this ability to design different molds and prepare for different researches. Here you can see the washing machine. The washing machine is necessary for testing of wear. This machine is in our mechanical lab. Is designed according to ISO specification to evaluate the wear by 3 or 2 body wear. We have different cycling machine. Thermocycling. Thermocycling is a machine which is needed for many tests, for many projects, because usually we have to mimic the changes of temperature in oral environment for in vitro tests. And also the load cycling machine actually is a mechanical machine for measuring the fatigue behavior of materials. And the pH cycling machine, which is designed by our PhD students, this machine can mimic the pH changes of oral environment. Okay, and also for, as I told you, for many research, you need to cutting machine. You have to first prepare different thin samples to evaluate any, when you want to set up a test method. First, you need to prepare thin sections. So you need 2 different cutting machines. In our department and dental school of Veterinary University, we have both low speed cutting machine and high speed cutting machine and CNC. Me myself usually prefer the low speed cutting machine because it induces less stresses. For many samples, especially for thin samples, maybe the high produced stresses resulting from high speed cutting machines damaged our samples. So usually I prefer the low speed cutting machines. But sometimes for some samples, maybe we need 2 high speed cutting machines to save our times. And also, in some cases, the low speed cutting machines cannot cut the samples. For example, maybe for metallic samples, maybe the high speed cutting machine be preferable device over the low speed cutting one. Here you can see a very delicate and precise section which we prepared with our low speed and high speed cutting machine is zirconia, and you can see here a very thin section of tooth structure. As I told you, for many research studies, we need these machines to prepare thin sections. Okay, so up to here, I told you that for a research project, first we need different accessories and devices to prepare a specimen. We need 2 different molds. We need a thermocycling machine to mimic the temperature changes of oral environment. Maybe we need to cutting machine or different accessories and devices which we need to prepare a sample and starting our main test. Up to here, I'm going to talk about how to measure, how to evaluate the mechanical properties of materials. You know that the mechanical properties of dental materials is very important for us because a foreign material which we apply on the oral cavity have to tolerate different forces, different applied forces, different mastication forces. The direction of these forces may be in tension direction, maybe be compression, shear, or maybe torsion, bending, or bucking. So this material have to tolerate different forces which apply in oral environment of that material. Before starting talking about the different mechanical properties, I am talking about some definitions in mechanical science. The force, actually the meaning of force, the definition of the force is the interaction of two bodies with each other. When one body interacts with another body, this interaction generates force. And this force over the surface area of the subject produces the stress, which the stress is very important for us. This stress may cause the movement in the material, or if the material cannot move, the deformation happens. And we call this deformation in mechanical science as a strain, which you know the strain is unitless. And maybe, as you know, we have two kinds of deformation in mechanical science: elastic deformation and plastic deformation. The elastic deformation means that any changes, any deformation of any produced deformation on the material can come back to the original form. Upon unloading, any changes can come back to the original form. But the plastic deformation indicates that after the in this region, in the plastic region, upon the unloading, the changes of material cannot back to the original form. If maybe you have this question that the plastic deformation is bad thing, not always. Sometimes we need to the plastic deformation. For example, look at this grip. To making this this wire, we have to bend this wire permanently. We need to plastic deformation to bending a wire. So sometimes we need to plastic deformation, but usually we don't like to pass the elastic deformation. We can measure the elastic deformation, the plastic deformation, the final strength that the material can tolerate using universal testing machine, which is the universal testing machine have different components. The main component of the universal testing machine is unit cell, which you can see here, the unit cell of this universal testing machine. We have a universal testing machine in our department with different load cells, different load cells with different capacities. Here we have 4, 6, 20, 50, and 200 kilogram capacity of load cells. Maybe many persons think that the load cell apply load, not the load cell, just a force inducer, and converts a force as a tension or compression or pressure into an electrical signal that can be measured and standardized, and the machine can get the signals of load cell. Here you can see a schematic illustration of a universal testing machine. Here is its load cell, and here is a crosshead. Usually we regulate the speed of crosshead ourselves depending on the nature of the material. And also the universal testing machine needs to different accessories for measuring different properties, different strengths of materials. Before testing, the universal testing software of universal testing machine asks us different questions. we have to indicate the geometry of a specimen, the dimensions of a specimens, and also the direction of force. For example, we want the compressive direction, or maybe we want to tensile direction, or some questions about the geometry and dimensions of specimens. Okay, the output of universal testing machine is a diagram like this, is a curve like this. The first point is a proportional limit point. We set up the test design, and here you can see a compressive strain test. The data goes to the software, and finally we get this curve. In this curve, we can get many data from the nature and from the properties of that material. For example, we can know the nature of material. Is it a brittle material, or it is a ductile material, the strength of that material. Here, the first point is the proportional limit point, which indicates that up to this point, the relationship between the stress as a strain is proportional. After this point, the next point is E, which is the elastic limit, means that up to this point, any produced changes on the material is elastic, means that upon unloading, the changes can come back to the original form. After the elastic limit point, the material goes to the plastic region, means after this point, the changes cannot come back to the original shape, and we have the permanently deformation on the material. In this region, we have two important points: ultimate strand and final strand. The ultimate strand, fracture strand. The ultimate strand means that is the point that this is a final point that the material can tolerate the forces before fracture. After the ultimate strength point, the material goes to the fracture. So for any test design, we have to we have to design a material that the forces don't pass this point, because after this point we have a fracture. Here we can see this material subjected to tensile forces goes up to here. Here is the proportional limit and also elastic limit. Means that this material, the applied forces on this material just are in the elastic region. But in this figure, you can see this material subjected to tensile forces, but the tensile forces passes the elastic limit and goes to the plastic region, necking happens, and after that the fracture happens. So we have to consider that they don't pass the ultimate strength of the material, because the passing of from the ultimate strength means that this material is going to the fracture point. For setting up any test method, any mechanical test method for different materials, we have to consider, I told you in my previous slide, that we have to consider to the nature of the material. It's a very important aspect. The brittleness or ductility of the material. We know that the brittle materials cannot tolerate, as I told you, cannot tolerate the tensile forces. And we have to know that the stress strain curve of brittle materials is like this. The fracture happens before any plastic deformation or little plastic deformation. Okay, we have different mechanical test methods for measuring dental materials' mechanical properties. The flexible strength test, we have three different kinds of flexible strength tests: 3-point bending, 4-point bending, and biaxial flexible strength. which are suitable test methods for evaluation of mechanical properties of dental composites, dental ceramics, and also dental cements. The compressive strand is a suitable proper test method for evaluation of mechanical properties of brittle materials like dental amalgams, gypsum products, and also different brittle biomaterials, maybe different brittle scaffolds, or maybe different synthesized materials. The strand is a proper test method for evaluation of mechanical properties of rubbery materials like impression materials. The fracture toughness indicates that we prepare pre-notched on the samples before the test. The fracture toughness may be done for different materials like ceramic materials. For brittle materials, it's very important to consider that in brittle materials like dental ceramics, usually the fracture starts from a crack. So in this test methods, we prepare a pre-crack on the material ourselves. And finally, the hardness is a mechanical evaluation of a surface mechanical test, which we have all of these test methods on our department. First, the compressive strand test. This is the accessory of our department in Dental School of Tehran University. The compressive strand test actually is a very simple test method. If we can, I prefer to if the compressive test be a suitable test method for evaluation the properties of a special material. I prefer this test method because it's a very simple test method. Here you can see an amalgam material that we are prepared according to ISO specification. And as you can see here, the compressive strand test is a simple test. We apply a plate downward on the surface of paper samples, and in this way we can measure the compressive strand of the material. As I told you, we have different kind of flexural strand tests, 3-point bending and 4-point bending. The difference between the 3-point and the 4-point is the just applying force. The point of applying force in 3-point bending is in 1 point, and in 4-point bending we apply the force by 2 points. Here you can see these are accessories for measuring the 4-point pentiflexural strand. What we can obtain from the universal testing machine, here you can see these are devices, these are accessories in our department for measuring 3-point bending. What we obtain from universal testing machine is the fracture, the final force that the material can tolerate on the fracture point, which we know this as P, and so we know the fracture point of the material now. We put the fracture point of the material in this equation. The P is the fracture point, L is the length between two supporting span. And for a 4-point bending flexural strand, we have two different points for applying loads. And just the equation of the 4-point bending and 3-point bending are different from each other. Here, again, we get the fracture point from the universal testing machine. Many scientists prefer the 4-point bending flexural strands because over the 3-point test, because the stress between the central loading span is constant. Is claimed that this kind of flexural strand is better than the 3.1. But you have to consider to your devices, your facilities, your accessories. Fortunately, we have both of them in our department. Another test method is biaxial fracture strength. This test is preferred by some scientists to avoid the problem of edge fractures. We have these accessories too for evaluation of biaxial fractures, and some of our researchers chose this device for measuring the strength of ceramics, especially ceramics materials. It is claimed that the fracture strength test methods are suitable test methods for prediction of clinical performance of ceramic materials. For so many scientists and also according to ISO specification, different fracture strength tests suggested for evaluation the mechanical properties of ceramic materials. As I told you, in the fracture toughness test, we prepare a crack ourselves to mimic the condition of ceramic materials. As I told you, in most ceramic materials, the fracture happens and it starts from a defect. And so me myself like this test because I think it can mimic better the fracture mechanics of brittle materials like ceramics. The applied force for fracture toughness test is downward. And here you can see the fracture starts from our pre-prepared crack. Here is obvious the pathway of crack. The another mechanical test is hardness. Actually, the hardness is a hardness test measure the surface mechanical properties of materials. For measuring the hardness, we have different hardness devices: Brinell, Vickers, Noob, and Rockwell. The difference between these devices are just in their indenter. For example, Brinell have a ball shape indenter, and Vickers and Noob have a diamond shape indenter. We have in our department the Vickers hardness test machine. In the Vickers hardness machine, the shape of indenter is diamond shape. We apply the indenter on the surface of the material. According to the hardness of material, we can produce different diamond shapes with different dimensions. We measure the dimensions of this diamond, produce diamond on the surface of the material, and in this way, we can measure the hardness of the material. Okay, the adhesion test also very important in dental sciences. We have to consider that actually in dentistry, when we apply a fine material on the cavity, the interfaces are very important for us because in dentistry usually we have to consider the interfaces. A bad interface leads to secondary caries and finally leads to the failure of the restorative. First of all, I'm going to talk about some definitions about the adhesion science. Adherent indicates the materials that we want to attach to each other. The adhesive is the material between the adherent, which attach to adherent to each other. And cohesion indicates the attraction of same molecules in a same material in each adherent. And adhesions indicates the attraction between different molecules of different adherents to each other, or maybe adherent to adhesives. In evaluation of adhesion and adhesion test, we have to consider that the measured bond strength and the failure mode is dependent to different factors, including the existing flows within or between the materials, the specimen size, and also their geometry. I tell you that we have two different kinds of adhesion tests, micro tests and macro tests. And the size of materials is very important for measuring the adhesion of materials, and also the nature of the adherent and also the adhesive. And so we have to consider that the measured bond strength depends on different factors. We have two different kinds of adhesion tests, as I told you, macro and micro. For each one, we have different forms according to our assembly or loading direction, shear, tensile, and also interfacial fracture toughness. Both macro and micro have all of these test methods. Fortunately, we have accessories for doing all of these test methods in our department. Some advantages of micro tests. Via the macro test, we can obtain multiple specimens per tooth. It's very important. Finding a healthy tooth is difficult in all countries. And also, we have to consider that smaller test specimens are stronger than larger ones because for smaller test specimens, we have the lower probability of having a critical size defect. And also, the chance of cohesive failures is fewer for micro tests because of, as I told you, for the critical defects, the defects with critical size are less in micro specimens. But the micro specimens have some disadvantages, including they can easily dehydrate, they can easily damage, and also many pre-fracture failures may be happened in micro specimens. But usually now more scientists prefer the micro test. I think maybe the most important features for choosing the micro test is the multiple specimens, obtaining multiple specimens per tooth, and also fewer cohesive failures. These are two important factors for these are two important features for doing adhesive tests. So most scientists prefer the macro test, and it is claimed that the macro test is better than the macro test. First of all, Chevron, I'm talking about the Chevron Strand test is almost a simple test method. The macro one is very simple. We can do the Chevron via two ways, a knife, a chisel, and also via loop. This is our accessory, the accessory of our department. This is the knife edge chisel. These are also our accessories. We have different knife edge chisels. This is the wire loop test method. In wire loop test method, we have two adherent. Here is adherent 1. Here is adherent 2. We loop a wire around the adherent 2 and apply a force upward and measure the Chevron strength. For a knife edge chisel, we apply the force downward. And it is claimed that the stress distribution in wire loop is better than, is more uniform than the knife edge chisel. If you would like more about the different test methods, different macro and micro test methods, I suggest you to read these papers. These are very useful papers, and in these papers, the stress distribution of different macro and micro test methods compared with each other, and so I suggest you. The tensile binding stress, usually no scientists use micro tensile binding stress. This is the accessory of our department. As I told you, the macro test has some advantages over the macro one. And it is claimed that the tensile binding stress, in tensile binding stress, we have more uniform stress distribution over the shear bond one. And so many scientists, many researchers prefer the tensile bond rather shear bond strength. So overall, if we have to have overall comparison with this test, I can suggest you that between the micro and the macro test, the macro one is preferable, and between the tensile and shear, the tensile is better. So I can suggest that, from my opinion, the macro tensile bond stress is the best one. But me myself now prefer to measure the bond stress of different adherent to each other using interfacial fracture toughness test. Considering the high discrepancies in the bond stress results found in different research, for the same adhesive tested by different laboratories and also by different researchers and by different tests, leads researchers to consider other testing approaches. In interfacial fracture toughness, we usually prepare a pre-notch. Here you can pre-prepared notch, and apply the load via different test methods, maybe via 3 bending forces, via 4 bending flexural strength. And the main question is, what's the final goal of measuring bonding strength? If you are interested in evaluating bonding differences among the products, we have to move to the fracture mechanism approach and measure the power of a stable crack propagation via K1C, which shows us the resistance of a material to crack propagation, or via G1C, which is the needed work to separate the adhesive resin from its bond to subdentin or any substrate. So in the interfacial fracture toughness, as I told you and showed you, we prepare a pre-notch here in the interface of two adherents and applied force, and measure the interfacial fracture toughness. Some scientists prefer to do micro interfacial fracture toughness. This is one of my papers about the mini interfacial fracture toughness. We prepared our samples in this way and applied our force via 4-point bending flexural test. We prepared a pre-notch here in the interface between two composites, and finally we measured the interfacial fracture toughness using the K1C equation. Here you can see this is adherent 1, this is adherent 2, and this is the interface, and we prepare a pre-notch here in the interface of two adherent and apply force in a downward direction as a 4 bending flexural strength test. The last test method for measuring the bond strength of materials is a push-out test. A push-out test is a suitable test method for measuring the bond strength between the filling materials inside the root surfaces. This is suitable test methods for many endodontic materials. For this test method, first we fill the root canal surface with any material that we want to test. After that, we prepare different sections, usually 1 millimeter sections, and put these sections and prepare as a disc here. These are our accessories in our, for push-out test in our department. Put the disc here and attach this accessory to upper jig and apply the force downward to push the material from this hole. You can see here. So the push-out test, the process of the push-out test is like this. First we fill here and put the disc here and apply the force downward to push the material outward the root canal. Okay, up to here, I talked about different accessories that and different equipment that we have in our mechanical and physical lab. Also, we have different materials. I don't have enough time to talk about all of them, but you have to consider, as I told you, when you want to measure the properties of a material, you have first to think about the usage of the material. After that, you have to consider to the nature of the material, and after that, you have considered to your facilities. Our second lab is the lab of synthesis of biomaterials. We have different equipments and also different accessories in this lab. Is the view of our synthesis lab. We synthesize different materials, the bioceramics materials like hydroxyapatite, fluorohydroxyapatite, different bioglasses, amorphous calcium phosphate, different nanobiomaterials, different biopolymers, different solutions in this lab, and different papers published by the scientists who work here. These are just some of this our publication in Dental School of Tehran University. All of these materials are synthesized in this lab. In the lab of synthesis, we have different equipment, like the different and also different chemicals. A microscope, different accessories, and furnace, incubator, wet and dry incubator. Here you can see autoclave for hydrothermal synthesis. For example, me myself synthesize titanium nanotube using this autoclave, and also this is centrifuge, and almost we have all facilities for synthesizing of different materials and different nanobiomaterials. Our third lab is a laboratory of biomedical analysis. We have we have three high-tech equipment here: X-ray diffraction analysis equipment, FTIR, which is equipped with ATR, and also STA or simulated thermal analysis device. I just briefly explained about these devices. Excuse me. First of all, I'm talking about the Fourier transform infrared spectroscopy, which, as I told you, our FTIR is equipped with ATR, is a very useful accessory for this device. Fourier transform infrared spectroscopy is a widely used vibrational spectroscopic technique for analysis of different chemicals, different chemical compositions, and different biomaterials. In this device, IR emits from the source and absorbed by photon. Subsequently, the photon converts to its simulated form, and the simulated form can vibrate different bonds of materials, different molecular bonds, and bonds in functional groups. Here you can see the pathway of IR comes here, but it goes to sample and vibrate the molecular bonds of sample. And here we can obtain a diagram. Here you can see this diagram for different functional groups. For example, and the vibration modes can be in different forms. For example, in symmetric stretching forms, here is symmetric, antisymmetric, rocking, and scissoring, like a scissor. Here you can see the scissoring form, and twisting, and banging. You have to consider that for a certain functional group, maybe we have different kind of vibration modes. For example, here you can see OH2 is the antisymmetric vibrational mode of OH2, and here is symmetric mode, and here is the scissoring mode. And also for CO2, here is symmetric stretch mode and bending mode and asymmetric stretch mode. According to the vibration mode, here, for example, is the vibration mode of OH, maybe, I don't know, maybe the symmetric mode of OH, maybe we have the antisymmetric mode of OH in different region of this graph. So according to this graph, we can estimate the composition of the material. As I told you, our FTIR device is equipped with ATR. I have to consider that the FTIR is actually a destructive method for measuring for analysis of materials, because for this test method we have to convert the materials to the powder form. For example, if we want to evaluate an enamel via FTIR, we have to analyze changes of enamel via FTIR. We have to powder the enamel. It's very difficult to convert enamel structure to a powder form. But FTIR helps us to use the material as their original form, and so the ATR is a non-destructive method. Just is enough to put the sample here and emit the IR and get very useful data from the material. The FTIR have different applications in dentistry. We can now mineralize tissue characterization. You know that, excuse me. You know that the nature of tooth structure have phosphate groups, have phosphate functional groups. So with measuring the phosphate content, we can know the content of phosphate groups via FTIR. With measuring the phosphate content, we can know the mineral content of tooth structure, or we can evaluate the demineralization and also remineralization process of the tooth structure. And also by measuring the content of amide, we can know the organic content of tooth structure. You know, for some research, maybe we need to know the organic content of materials, or also the carbonate is important. For example, for laser irradiation, you know that the laser can destroy the carbonate content. So FTIR can help us to know, to get many useful data from the mineralized tissue, enamel chemical characterization, chemical characterization of dentin, and the maturity and also the crystallinity of tooth structure. Is a useful equipment for measuring de-graft conversion of dental composites. And also via FTIR equipment, we can characterize different synthesized materials, unknown materials. And also, as I told you, we can measure the DEM and REM process. The next equipment which we have in our department in the Dental School of Tehran University is X-ray diffraction analysis, which is very useful equipment for evaluation of crystalline structure of materials. The explanation about the X-ray diffraction is beyond the scope of this presentation, is a little complicated and also needs to more time. But briefly here, I indicate just some benefits, some usage of this equipment in dentistry. Here is a schematic illustration of how it works. We irritate some X-ray whenever that, I don't know that you know anything about the plans, the crystallographic plans. Here you can see the crystallographic plans of a material, a certain material. These are the crystallographic plans. Whenever that the X-ray pass the parallel crystallographic plans, they can diffract the X-rays, and whenever that we have the diffracted X-ray, here we can get a peak. Here we can see this emits to this sample, rotates, and this emits to this rotated sample. Here with the diffracted beam, in the diffracted beam here, diffracted beam gives us here a peak. This peak is a fingerprint for each material. Here, this inside our device, we put the sample here. The sample rotates, and the X-ray emits the sample. And whenever that the material can diffract the X-ray, we can get a beam, a peak. And this peak is, as I told you, is a fingerprint for each material. This is the X-ray diffraction graph of hydroxyapatite, which is an important material for us to evaluate different changes in dentin or enamel or also bone. For example, here you can see the main X-ray diffraction peak of the hydroxyapatite is in 26 degrees. As I showed you, the samples rotates, and whenever that can diffract the beam, we have a peak here. Some application of X-ray diffraction techniques, identification of unknown faces. We can put unknown faces in the X-ray diffraction, and via the obtained graph, we can estimate, in addition with other analysis like FTIR, we can estimate the structure of the material. We can measure the lattice parameters, measure the crystalline size is very important. Many test methods, many treatments may cause changes in crystalline size. Via X-ray diffraction, we can measure the crystalline size of materials. We can measure the internal strain of the crystals is important in dentistry because we know that the internal strain are important in dentistry. We can also measure the residual stresses. For example, residual stresses produced in ceramics between the, for example, the two layers of ceramics is very important to know. The residual stresses, the Easter diffraction can help us to measure this, the residual stresses. Also, we can measure the phase transformation and also the percent of crystallinity of materials and also the orientation of crystallites in the material. This is one of my publication. Comparative assessment of crystalline structure of powder and bulk human dental enamel using X-ray diffraction analysis. In this research study, we showed that the pattern of the diffraction pattern of bulk and powder enamel is different from each other. You can see in the bulk form, our main peak is in 002 crystallographic plan, but in the powder form is different. We measure also the lattice parameters of enamel in two forms of powder and bulk, and obtain that the lattice parameters are the same in both forms. We also measured the crystallinity of human dental enamel in powder and bulk and obtained that in powder form, the crystallinity of a human enamel is more than the bulk form. And here, finally, we measure the crystalline size of bulk and powder form, and we obtained that the powder form, the bulk form have a larger crystalline size than the powder one. The last equipment that I want to introduce you is simulated thermal analysis. For evaluation the thermal, we have this device in our department, fortunately, the simulated thermal analysis. I describe more about this device. To evaluate the thermal behavior of a material, we can use different equipments like differential thermal analysis or DTA, differential scanning calorimetry or DSC, thermogravitometric analysis, thermomechanical analysis or TMA, and also dynamic mechanical analysis or DMA. The STA is the combination of DSC and TGA. Which both of them, the TGA and also the DSC, are very important devices to show us the thermal behavior of a material. The thermogravitometric analysis or TGA shows us the changes of the weight of a material compared with the changes in changes of temperature. For example, with increasing in temperature, maybe some parts of a material burn or maybe evaporates. Also, using the TGA, we can estimate when a material, which part of the material evaporates or which part of materials burns or something like this. And so, we can estimate an unknown material, or we can also estimate the behavior of the material. And so we can know maybe for some materials we have to consider that if we want to do any thermal treatment, we have to stop our thermal treatment up to this point, because after this point the materials goes to burning or maybe goes to evaporation. Some parts of materials goes to evaporation. So we have considered the changes of weight of material, and we can measure these changes using the thermogravimetric analysis. The DSC, or differential scan calorimetry, also measures the temperatures and heat fields associated with transition in materials as a function of time and temperature in controlled atmosphere. Here you can see different usage of DSC. We can use the DSC for glass transition to measure measuring the glass transition, for measuring the melting and boiling points, for measuring the crystallization time and temperature, the percent of crystallinity of materials, heat of fusion, and also a specific heat capacity and oxidative stability of different materials, and also rate and degree of cure, and also reaction of kinetics, and also purity of materials. Also, we can use this device for measuring the degree of conversion of dental composites via a special method. Here you can see a DSC thermogram of a material. Here is the glass transition temperature. After that, the material goes to the crystallization. So sometimes, for example, when we want to make bioceramics, we have to consider that after this point, for example, for a special material, we know that after this point, the material goes to crystallization. So if we want to make bioceramics, we have to apply heat over this point. After this point, you can see here the material goes to melting. For many materials, we don't like melting, or it depends on our usage. We have to, but this is an important device to show the different temperatures. As you can see here, this is oxidation temperature. So we have to consider that this material can tolerate the temperature up to this point before oxidation. DSC in combined with TGA are useful devices for giving us important information about the thermal behavior of materials. All of these devices that I showed you and described about their action briefly with each other can help us to design a research project and to estimate the behavior of material, to know the properties, the composition of material. And you have to consider that when you want to design a test method, as I told you in my first slide, in my previous slides, you have to consider your usage. Maybe for some materials, we need most of these test methods for evaluation of mechanical properties. We have to consider that which most test methods is better than others. We have to consider, as I told you, to the nature of the materials. I told you that me myself prefer the interfacial fracture toughness test, but we have to consider that in many cases we don't use this test method. For advanced research, maybe we need some of equipments that I showed you, like X-ray diffraction analysis, or maybe FTIR, or DSC, or TGA. Fortunately, we have these devices in our department, Dental School of Tehran University. If you have any question, thank you for your attention to my presentation. If you have any question about the evaluation of the properties of the materials, please ask me. Don't hesitate to ask me. Here are my email addresses in the case that you have any question. Wish health and happiness for you. Goodbye.
Thank you very much, Dr. Behrouzi Bakhsh. That was very interesting lecture. And we don't have any question. or no, nothing. And we should end this session. And thank you very much, everyone. And I hope you enjoyed that.
Hello, everyone, dear students. Thank you very much for being with us. And I would like to let you know that at the end of this day of our course, we have a great presentation by Professor Dr. Mohammad Hossein Nekufar. Let me give you a short introduction of Professor Nekufar. He's Associate Professor of Endodontics Department, Tehran University of Medical Sciences, and also he is Director of International Relations of Tehran University of Medical Sciences. Beyond a faculty member, he's mentor of international relations in our school, and especially he's my mentor. And I would like to thank Professor Nekufar for accepting my invitation to this panel. And I see that you are at your office, and I know you are very busy these days, and it's very kind of you to